Welcome to the deep dive. Today, we're really getting into a foundational piece of research in vascular surgery.
Hmm.
You pointed us to a great chapter. It's from 50 landmark papers every vascular and endovascular surgeon should know.
Right, a fantastic collection.
And we're zeroing in on one study from that,
Hmm.
looking at the long-term results of in situ saphenous vein bypass
Hmm.
for really severe leg ischemia.
Yeah, a critical topic.
So our mission, basically, is to figure out why this paper became so important. What did the data actually show about how well this technique works for saving limbs?
And it's crucial context because limb-threatening ischemia,
Yeah.
it's just devastating. Surgeons have been working for ages to find the best ways to restore blood flow, prevent amputation,
Right.
and bypass surgery has always been central. But this paper, it tackles that big question. How do you get bypasses that don't just work now, but stay working reliably long term?
Especially below the knee.
Exactly. And this chapter singles out the 95 Shaw paper on the in situ technique as a real landmark. Makes you wonder, doesn't it?
Yeah. How could a technique that seems, well, pretty logical, just use the vein where it sits,
Mhm.
how could that have such a lasting impact enough to be in this book?
It's a great question.
Okay, let's dive in then. Before in situ really gained ground, what were surgeons doing? What were the earlier approaches?
Well, for a long time, the main player was the reversed saphenous vein graft.
Reversed, okay.
Yeah, so you'd surgically remove the saphenous vein, flip it completely end over end.
Mhm.
The main reason was to deal with the valves inside the vein. They only let blood flow one way.
Okay, so flipping it bypasses the valve problem.
Correct. But doing it that way brought its own set of technical challenges.
Such as?
A big one was size mismatch. Veins are naturally wider, closer to the groin, and narrower down by the ankle when you reverse it.
You're connecting the wider end of the vein to the smaller artery further down the leg and the narrow end up top.
Exactly, like trying to connect, different size pipes. Not always ideal.
Got it. So what was the sort of core idea, the innovation with the in situ approach?
The thinking behind in situ is, well, elegantly simple, really. You just leave the vein where it is in its natural place.
Right there in the leg.
Right. And doing that gives you a much, much better size match automatically. The vein diameter naturally tapers along with the artery it's being connected to.
That makes sense. And this is where certain names pop up, right? Doctors Leather and Carmody.
Mm-hmm.
The chapter credits them with really developing a practical way to do this.
Oh, absolutely. They were pivotal. They really refined the surgical steps needed to make in situ work reliably.
How so?
They developed and really championed methods to carefully disrupt those valves inside the vein, but without wrecking the vein wall itself. That was the key hurdle.
So you can get blood flow through it in the right direction without taking it out and flipping it.
Precisely.
Now, the chapter mentions some early pushback. Even a bitter battle, it says, between the reversed vein camp and the in situ folks. What was the argument about?
Oh, yeah, there were strong opinions. Definitely. Some prominent surgeons, like Doctors Connolly and Robb mentioned in the chapter, had concerns.
What were they worried about?
They questioned if the in situ technique might just take too long in the operating room, and also the risk of AV fistulas.
Fistulas, yeah.
Yeah, small sort of abnormal connections that could sometimes form between the vein graft and little nearby artery branches that weren't properly tied off. They needed extra attention if they formed. So the worry was maybe these issues offset the benefits.
Right. You don't want added complications.
Yeah.
So what really tipped the scales? What developments made in situ more accepted?
It really came down to dealing with those valves safely and effectively. That was the main technical block.
Okay.
The development and refinement of instruments and techniques for what's called valve incision, or valvulotomy, basically, cutting the valves to render them incompetent without damaging the vein, that was the game changer.
Made it much more practical.
Exactly. It took away a major hurdle and made in situ a much more attractive, viable approach for many surgeons.
All right, so that sets the stage perfectly. Which brings us to the study itself. Shaw et al., 1995. What were they setting out to prove or investigate?
Their main goal was pretty clear. They wanted to look hard at the results, not just short-term, but mid and especially long-term. How well did these in situ bypasses actually perform over time?
Performance meaning, did they stay open?
Yes, exactly. What we call patency, were they still open and allowing blood flow? And the bottom line, how effective were they at saving the limb, preventing amputation, limb salvage? They needed solid data.
And the scale of this study, looking at the numbers, is pretty big.
It really is. They analyzed, let's see, 2,058 in situ saphenous vein bypasses. This was done between 1975 and 1995.
Wow, 20 years of data.
Yeah, and it was part of a larger pool of over 3,000 bypasses using the patient's own vein. And crucially, most of these patients, 91%, had limb-threatening ischemia. So these were high-risk limbs.
Really the patients who needed it most.
Absolutely. And they also noted a high initial success rate. They were able to actually complete the planned in situ bypass in 88% of cases where the saphenous vein was okay to use.
That's encouraging right off the bat. And where were these bypasses going mostly?
Yeah.
Down the leg.
Predominantly, yes. About 69%, so more than 2/3, went to the infrapopliteal level.
Below the knee.
Below the knee, yeah. Often to the tibial arteries, which are smaller, further down, technically more demanding procedures. And they mentioned mostly using the modified closed in situ technique.
Okay. And you mentioned long-term follow-up. How long are we talking? That seems key here.
That's one of the study's biggest strengths. They managed to follow up on 95% of their patients for up to 120 months.
10 years.
A full decade. That's serious long-term data. And it wasn't just casual follow-up. They had a strict protocol. Physical exams, checking pulses, measuring blood flow with things like pulse volume recordings and segmental pressures, plus duplex ultrasound imaging. Really thorough monitoring.
And they sliced the data different ways too, didn't they? Looked at subgroups.
They did. They compared outcomes based on things like bypass length, long versus short, vein size, small versus large, even the specific technique used, open versus closed, though closed was more common, and patient factors like diabetes or sex.
Okay, so they gathered all this data, followed patients for years.
Yeah.
What did they actually find? What were the big results on effectiveness?
The findings were, frankly, very impressive and really supported the durability of the technique.
Yeah.
For primary patency, that's the bypass staying open without any extra procedures needed.
Right.
It was 84% at 1 year, still 72% at 5 years, and remarkably, 55% over half still patent at 10 years.
Wow, 55% at 10 years without needing anything done. That sounds pretty good for such complex cases.
It was considered excellent. And then there's assisted primary patency that includes cases where maybe a small procedure was needed to keep the graft open, like angioplasty.
Okay.
Those rates were even higher, 91% at 1 year, 81% at 5 years, and 70% at 10 years. So 7 out of 10 grafts were still functioning after a decade, perhaps with some maintenance.
Those are strong numbers.
Yeah.
What about those subgroups? Did things like vein size or diabetes make a difference? That seemed to be a concern earlier.
That's one of the most interesting parts. They found no statistically significant difference in patency based on whether the bypass was long or short, the vein diameter used, or whether the patient was male or female, or diabetic versus non-diabetic.
That's huge, especially the diabetes finding and vein size. That must have reassured a lot of surgeons.
It certainly did. It suggested the technique was robust across different scenarios.
And the ultimate goal, saving the leg, what were the limb salvage rates?
Truly remarkable. I mean, this is the payoff for the patient. At 30 days post-op, 99% limb salvage.
Almost perfect.
And it stayed incredibly high. 97% at 1 year, 95% at 5 years, and even after 10 years, 90% of patients still had their limbs saved by this procedure.
90% at 10 years.
Yeah.
That's life-changing. Absolutely.
Undeniably.
So putting it all together, what was the main takeaway message from Shah and his colleagues back in '95?
Their conclusion was pretty emphatic. They stated that the in situ saphenous vein is an excellent conduit, a great pipe for bypasses going from the thigh down below the knee, even to the lower leg arteries, specifically for saving limbs.
Right.
And importantly, that factor is often thought to be critical, like where the blood flow came from, how long the bypass was, which specific artery it went to, or even how wide the vein was, didn't seem to significantly hurt the immediate or long-term success.
You can see why this paper made waves. The chapter calls it one of the first to really offer that kind of solid long-term proof for what was still a relatively new technique then. How did it really change things in practice?
It was hugely influential. It provided strong evidence that in situ wasn't just, technically possible, but that it delivered durable, lasting results.
Moved beyond just anecdotal success.
Exactly. It helped solidify it as a reliable and, importantly, teachable technique. Compared to what was known about reversed vein grafts back then, which often showed a bigger drop-off in patency by 5 years, these results looked very, very good. It really showcased the potential here.
And it tackled those early worries head-on, didn't it? The concerns about patency compared to reversed veins.
Absolutely. It provided powerful data suggesting in situ patency was at least as good, maybe better in the long run, than historical reversed vein results. And like we said, it calmed fears about using it in women women or diabetics, showing similar success.
So it broadened the confidence in using it. Did it encourage surgeons to be maybe a bit more aggressive in trying to save limbs?
I think that's fair to say. This paper definitely contributed to surgeons feeling more confident, tackling more distal bypasses, going further down the leg, even into the lower third.
Which maybe they wouldn't have attempted before?
Right. There was maybe a feeling that those really long bypasses to tiny arteries were just futile. This study challenged that idea. The commentary authors point that out before this, many were hesitant about such long, technically tricky bypasses.
And the group behind this paper, they didn't just stop there, right? The commentary notes their ongoing experience.
Yeah, it mentions that the same group, over the decades, has now done something like over 6,000 in situ bypasses
Wow.
and maybe 15,000 leg bypasses overall. It just highlights the incredible depth of experience that grew from this foundational work. In situ bypass is still absolutely a key tool today for limb salvage, working alongside all the newer endovascular stuff too.
It's a lasting legacy.
Hmm.
Now, we should touch on limitations. No study's perfect. What did the chapter highlight as limitations of this Shaw paper?
Right. Important to be balanced. It was a single center study. That's always a consideration. Can these results be replicated everywhere by different teams?
Good point.
Also, the patient selection. It was mostly de novo cases, meaning first-time bypasses where the saphenous vein was intact and generally good quality. It didn't really reflect the more complex picture you get with reoperations where the vein might be damaged or scarred.
So maybe the results look a bit better because they started with more ideal candidates.
That's a potential selection bias, yes. And technically, it was a retrospective look at data they'd collected prospectively. Not quite the gold standard of a randomized controlled trial, though still very valuable. The single-center aspect did raise questions initially about generalizability.
Understood. Important context. So, wrapping your head around all this,
Mm-hmm.
why should you, our listener, really care about a study from 1995? What's the connection?
Well, because this research isn't just academic, it's about a technique that directly, profoundly helps people keep their legs, people facing a really frightening diagnosis.
Yeah.
The aha moment, I think, is seeing how that detailed surgical work, combined with really careful long-term data tracking, translates into saved limbs and better lives. It shows the power of evidence in surgery.
Totally agree. It's that link between the technical skill in the OR and the long-term real-world outcome for the patient. Fantastic. Okay, let's try and sum up this deep dive. What are the absolute key takeaways from Shaw et al.? Why is it a landmark?
I'd say the big things are: 1, it showed excellent long-term patency for in situ bypass. 2, it demonstrated truly remarkable limb salvage rates, even out to 10 years. 3, it provided strong evidence that factors like bypass length, vein size, or diabetes didn't necessarily doom the procedure.
Right.
It basically gave surgeons the confidence and the data to embrace in situ bypass as a durable, reliable cornerstone for saving legs threatened by severe ischemia.
A really pivotal piece of work. So, final thought here. Thinking about how surgical techniques evolve and how powerful long-term data like this can be, what other areas of medicine, maybe practices we see as standard now, might still hold surprises or potential for, even bigger improvements if we keep digging, keep researching, keep refining?
That's a great question to ponder.
It just hammers home how vital that ongoing, rigorous research is for pushing medicine forward and improving patient lives. Thanks for exploring this one with us today.